So, last chapter was OB, birth, all that great fun stuff. So now we're going to get into pediatric emergencies. This is kind of a long chapter, so I'll try to breeze through it as much as I can, but I also want you guys to learn what you need to learn. So, like I always say every class, read your book, read your book, read your book. Um, so there's a lot to cover. So the development and characteristics of an infant and children. Um, is important when you do patient care. I can ask every EMT class, every EMT team that I've ever worked with, which is only three, but what's the biggest concern they have? What makes them most nervous? The two main answers I always get is cardiac arrest and pediatrics, babies. And the truth is babies are it can be scary, but they're just smaller adults. There's not a lot different in how we take care of them, but knowing the anatomy differences is what helps us. So, pediatric newborns and infants is birth to 1 year, which is also called a neonate, is medical terminology. So, birth to 1 year is what we call newborns, infants. Toddlers is 1 to 3, preschool 3 to 5. So, just remember and then pediatric age and categories of school age is 6 to 12, school age, and then adolescence is 13 to 18. So the main thing that just remember your lifespan development chapter and go back to that, all the different ages. So basically, when you know the differences, when you're 13 to 18, adolescence is kind of their anatomy is almost like an adult. So recommended. It says here not to rely on memory for recollection of normal vital signs during emergency. So one of the things I'm creating for our team is I was given by Children's Hospital, basically a pamphlet. It fits in your pocket and has all the vital signs for different ages and drug dosages for different ages. I'm trying to laminate those, and everybody will have one when you pass to carry in your EMT pants with your uniform. But it's good to not have to rely on memory for these things because all these different ages have different vitals. So the anatomic and physiologic differences. So the physiology of these kids is a little different. So when you're a child, infant and children, they have different mechanics. The physiology, anatomy, and all that kind of stuff. So when we want to understand these differences, so when we go on a call with a kid or an infant, there is going to be differences. So we're going to have to know those differences. So when you're checking ABCs, how you check them is even a little not different, but you got to understand the mechanisms of the body is different. So like the head, as you see in your book here, is different because the head is bigger than the neck and the body. And so you got to remember these heads. I think it's till age 4. I think it says in your book that heads are heavier than the body. In a lot of ways, because you got the brain, you got all that kind of stuff that's in there. So one of the things that they say never grows or changes is your eyes. Um, so the head is just bigger. And so when you look at this picture here, the kid's head is bigger than the body. So when he's laying flat, it shuts down his airway. And because you can see that right there where the chin is, that shuts it down. Where me and you as adults, we lay down, we don't have that problem. So when you have a kid that is laying supine where they fell down and you go up to him, you got to be aware of that when you're checking airway. Is his airway is already obstructed before you even check his to see if his airway's patent inside. It's already obstructed because of his head size. So yeah, right there, age 4, and always suspect injury of serious mechanism or MOI. So if the MOI is serious, expect an injury. And then you got the fontanelles, which is a soft spot at the top of the head. The skull's not healed up yet. It's not grown into that spot because it has to stay that way. For birth, they got, it's amazing how the body's designed. To be born, your head's got to reshape. So obviously that soft spot is there for that. And eventually your head grows and closes that up. But you got to look at that for kids. And that's one way to tell if they're dehydrated is that fontanelle is got a big indent in the head. It's caved in. So airway and respiration, mouth and nose are smaller. Everything's smaller. Tongue takes up more space because it's bigger. So the airway is smaller, the tongue's bigger, and so the nose is smaller. And typically these guys are nose breathers, so it's easier. It's hard to it's easy for them to obstruct their airway. Even if they got RSV or cold, you got to suction that nose to make sure they keep breathing because that's where they're breathing from. Um, and the trachea, windpipe, is softer, is not fully developed. You got to recognize that the bones are softer and they're developing to be as hard as they are for us adults. So is the airway, the trachea, and it's easy to obstruct things in there. Chest wall is softer, just because the bones are. So the diaphragm more involved in breathing. So when you look at these kids, you see that diaphragm moving. Um, kind of like if you see us as adults with hiccups, that diaphragm spasms. So the more involved that is, the more the body jerks. So it's kind of how they breathe too. You really see a lot of belly breathing because that diaphragm has to work. Um, and then they also got contents in the stomach. So the stomach, it doesn't take much for them to shut that diaphragm not down, but um, it causes difficulties for that diaphragm to fully function when their stomachs are full. Just the anatomy of the body. Um, the ribs are more box-like, so limited ability to take deep breaths, and because of this, they're nose breathers. And as nose breathers, like I said, if they get things up there, like they stick toes up there, they get colds and mucousy, can cause them to have difficulty breathing. The hyperextension or flexation of the neck may result in airway obstruction. So, looking back, looking forward, however they lay, like it says, those heads are top heavy. Basically, they're like little bobbleheads running around as babies and toddlers. So it's easy to obstruct that airway. And just a rule of thumb though is we don't do finger sweeps on infants and children because we could just shove that thing further down and dislodge it or get it stuck in that airway. And so here's a picture in your book that shows this, and you've probably been looking at it. The child has smaller noses. You can see that kind of the tongue that takes up the space there because the tongue's bigger. I like the picture here of the trachea being narrower. All that line over, it's narrower, and you look down below, it's more wide, and it's harder to obstruct. So just take a look at that picture and understand the anatomy. The structures are more easily obstructed right there where the mouth is, so when they swallow, it's easy or nose. I'm sorry, when that at the now where does that say airway structure are more easily obstructed. Follow that up, you can see that how tiny that airway spot is. So it's just basically the rule of thumb. It's easy. You got to know the anatomy, but really when you go on kids, everything's just smaller than adults. So obviously the common sense is the smaller the hole, easier it is to get something caught in it. Less developed, more elastic in young patients, the chest and abdomen. Infants and children are abdominal breathers, so we kind of said that with the diaphragm. Abdominal organs less protected than adults, so everything's still developing. So we have all that peritoneum and all that's going on. So with kids, everything's less protected than when we become an adult. Muscles not built up yet. The larger body surface in kids, there's more body mass than with adults, and more prone to heat loss through skin, and more vulnerable to hypothermia. So we covered that in the environmental emergency chapter. But just rule of thumb, the body's bigger mass than adults, so a lot of more heat's can be lost through the skin, and because of that, they're prone to hypothermia. And the blood volume, this is what's really interesting, as you can see in your book. It's less blood volume than an adult, obviously because they're smaller. Blood loss that might be considered moderate in an adult can be life-threatening in kids. So I love that picture here. You got a kid with 9-pound newborn, and it's 12 ounces. You spill. If we did this in class, and maybe we will, I don't know. We take a can of soda, throw it all over the bay area of the station or on the floor, and that's the blood of a baby. That's how much. That's all it takes. So you're not talking a lot of blood loss in that kid to cause problems. 60 pounds is a 2 liter, and then 125-pound adult 2 liter bottles of a soft drink. So not when you don't really think about that, but there's not much blood volume. It doesn't take much for someone to bleed out. And so we got to think of that when we go on these people. Picture that in your mind. If you go up to an adult kid and an infant and you see a can of soda, enough blood to fill a soda can on the floor, you're in trouble. So not much to. It's just pretty intense. But anyway, thought that was an interesting picture. So psychological and personality characteristics. Each age group has its own general characteristics of psychological and personality. So some children may cry when they see you since you are a stranger to them. Everybody's got their own personality, right? And everybody's personality is different. So, One thing you gotta look at though is they may cry and they may be fine. How many of you guys ever met a kid that didn't know a stranger? I mean, you take my middle daughter, Micaiah, into any restaurant, she's like a politician. She'll go from table to table. How you doing? What's going on? Hi, 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 hi. I mean, she just is a social butterfly when it comes to those things. Doesn't know a stranger. Then you got the other one of my daughters who hides behind Lori and me wherever we go. So when you got these people, they're just gonna be different. You gotta be able to adapt to their personality to help them. Never let the potential of upsetting a child prevent you from delivering appropriate treatment. If you're gonna save their life, right? So adapt and conquer. So just think about that. What techniques would you utilize when attempting to assess a crying infant? Learn their personalities, use the parents. I'm not a good technique guy with crying kids. I'm just being real. Surprise, surprise. But I don't do that. But there's toys, there's things that you can do. I transported a kid one time all the way up to the city and just, let him look at Netflix, watch Netflix on my tablet, and kept him calm while we took care of him. So just whatever you got to do, you do. Um, Interacting. So you can see there the guy's making eye contact. Always let them know what you're doing. I'm gonna buckle your seatbelt. I'm gonna put this on. It's gonna be check your BP. Sometimes what you got to do is check the BP of their stuffed animal before you check the BP on them. Let them see those things. Use mom to comfort as well. Whatever you're gonna do on the child, do on the mom. Show that kid it's okay. This is what's gonna happen. Um, the only time that might be difficult is when you're giving an IV, and you really don't do that on mom too, unless she's a patient. But just make eye contact, communicate, and you should be fine. Um, Identify yourself like you do with anybody else, so not much difference there. Hi, I'm Scott with Shine County Ambulance. I'm here to help you. What's going on? Let the child know that someone has called, um, or will call his parents. Always let them know if their parents aren't there, if you're at a school or whatever, let them know the mom's on the way, the dad's on the way, they've been contacted. They're going to meet you at the hospital, so it gives them a goal to get an ambulance. If no life threatening problems, continue at a calm pace during the evaluation process. No need to go crazy. If it takes you time, take time. Um, and then let them play, let them be kids. Smile, touch or hold child's hand or foot, um, to make contact. Do not use equipment without first explaining what you'll do. Like I said, if you need to do it on a toy, do it on a toy, or on the mom, or on a bystander. Let the child see your face. Don't ever hide your face. Rule of thumb is just always make eye contact, and use calm voice, and let them feel safe with you. Be at their level, like I said earlier. Kneel down at them, um, and stop occasionally to find out if the child understands. Hey, I'm going to put this BP on your arm. It's going to squeeze, and just make sure they understand before you push the button. Um, if they're bleeding, let them know, hey, I'm going to stop this bleeding so everything's going to be okay. And just reassurance, reassurance, and reassurance. I like how it says never lie to the child. Rule of thumb, don't lie to anybody. Don't ever lie to anybody. Um, like I said, twist the words around. Don't lie and don't twist your words around in a lie, but always be smart how you answer the truth if it's a bad truth. Um, if you know what I mean. If it's a car accident and one of the family members died, is my mom gone? Did my mom die? Is mom okay? My partners are with her. We're gonna take care of you. Your dad's on the way to the hospital. Just whatever you can do, but don't lie, and that kind of stuff. So, um, should be able to tell you exactly what happened and how they feel, and may not be completely communicative or cooperative if in front of parents or peers. So, rule of thumb, typical. Kids hide behind their parents. Kids use their parents. Parents speak on kids' behalf. So they're not used to that yet. But typically, when it comes to adolescence, I've never seen a kid that really gave me a hard time when nobody was around. It's just a matter of shyness. So if mom and dad are here, they're going to answer the questions, and that's okay. Just make sure you check the glass skill of the kid, make sure they're answering questions properly, be sensitive to the opinions of their peers, and may be intimidated by authority. Some of them might be embarrassed. If it's at school, they might be a little embarrassed. So just got to watch all those kind of things. Often embarrassed, worried about changes in body. So sometimes it's a vulnerable situation. Um, Sometimes it's just a sensitive situation. They're if you got to take clothes off, you got to do this or that. So just be aware of all that kind of stuff. Use privacy however you can. Do not delay evaluation. When possible, have the exam conducted by or in the presence of an EMT of the same sex as the patient. So if it's a little girl, try to use a little girl if there's a little girl on your team, on the partnership. Um, it's always better that way, guy on guy, girl on girl, for patient care, just because the world we live in, and no big things. Just you just never know. It's just never know. Um, there he is kneeling down. Be respectful. He's touching her, so he's bringing reassurance to her without being domineering. Knelt down, holding the shoulder. How's it going? What can I do for you? And just talk calm and cool and collective. So supporting the parents or other care providers. Possible reaction to child's illness or injury. So denial, shock, crying, screaming, anger, self-blame, guilt. Parents will go through that. Whatever. Whoever's the caregiver, daycare, school, aunt, grandma. They're always going to feel guilty. I know. I saw a kid get her finger about near cut off, and the sibling was just felt horrible. So, be respectful to that. Be reassuring. Things happen. Again, there's a difference. We'll get to later. There's a difference between abuse when you recognize that versus, oh man, an accident. So just reassure them. Let them know it's okay. Accidents happen. We're gonna take care of it. May interfere with care of child. So a lot of times these over zealous care providers, they feel bad, so they want to do everything, want to help. Now they're trying to overprotect. Not all children live in a traditional nuclear family. A lot of divorced parents, broken homes, all that kind of stuff. So um, there's a lot of times with these family dynamics, when things change to that degree, it can bring some insecurity, anxiety, all that kind of stuff. So you got to be aware of that. And then also, just this isn't in the chapter, I don't think, but just FYI, if there's a broken home and it's broken maybe because of domestic violence or whatever, you got to be cautious with that. I've had parents where one parent would come to the hospital, and then you got a whole different issue of who signs out the kid, who can, who can't, what's legal, just a lot of legal stuff. So be aware when you're working with a kid, if it's a broken home, why is it broken? Don't go, you don't have to go to, counseling on it or nothing. But I just had a weird situation a while back where they had to make it very clear to me that dad is not to pick up the kid at the hospital. Um, and so, with that said, it's hard because then you got to have legal documentation and all that. So, we'll go back to legal chapters on that. But just an FYI, be aware of those things. Ask to help by holding and comforting child and giving medical history. So, you see in the picture in your book, it's okay. That mom there is you know, holding the kid, keeping him comfortable, and she's able to hold the mask on. Our main care is that, or our main objective is that child gets the air, right? We don't care how. Let mom do it. You know, you just do what you can do and do your job, and let her do what she can do. So it's kind of cool that we can do that. I took a patient one time on a long transfer, and um, he was fine. He wasn't. He just had a problem with his airway, and so he couldn't swallow. And so basically, all the whole transport, he was fine, and he just suctioned himself instead of, because it took suctioning all the way to the city. He would just do it himself. He just held it, and he's like, I got it, because then when he doesn't have to flag me down every time, and he just suck it out and go back to sleep. So um, that was him doing it himself. But the point I'm trying to make is, it's okay to do those things. It's okay to let mom do those things. Make it easy. So assessing the pediatric patient, two viewpoints. So the triangle. So we talked about this last chapter. Um, Pediatric triangle, two viewpoints from the doorway, when you walk in, the remainder of the primary assessment done next to the patient. So you got to look at the fact that things really start when you walk in the room. And we've said that before, scene size up, all that. Well, with you do it with adults too. So what drives me nuts about this chapter is not a whole lot different. But with a kid, as soon as you walk in the room, you're assessing their behavior, their everything. So right here it says under elements. So you look at the appearance, cyanotic, not cyanotic, clammy, sick, not sick. You look at their appearance, how they look. Labor breathing, not labor breathing, skin pink, warm, and dry. All that is done as you're walking in, and you can check those things before you ever get to the patient. Um, determining if the scene is safe, rare risk from violence or abusive behavior, sometimes directed towards child. So again, objectively, is there abuse? Because if there's abuse, not only are we taking the kid on a ride to the hospital, we're going to report, that situation. Use standard precautions, PPE, evaluate scene for clues of accidental poisoning or um, applicable. So, I one time I know a kid that ate a whole box of decon. I mean, he didn't. Parents didn't mean to. It wasn't neglect. It just, you find a box of decon. It looked awesome, so the kid ate it apparently. And but you got to look for clues for those things too, because maybe the mom called you because the kid's just not acting right, but we don't know why. And then you find the empty box of decon, right? So always look for clues of accidental poisoning if applicable. And there's a picture of the triangle, right? So there's appearance, work of breathing, and circulation. As soon as you walk in, so picture that you walk in, and that's what you see. Okay, obviously that kid in that picture, it's a weird picture, kind of creepy, but at the same time he looks sick. It looks like he's labored, potentially breathing. But that triangle is what you look at. So then you got here, right? Scene size up. You walk in, you see this baby. I see that baby. I'm not thinking, oh man, that kid is sick. You got the rosy cheeks. You got a smile. He's making eye contact. Airways open. Everything looks good on that kid. So, good weight. Good. That's a really good looking baby there. So, when you walk in, you kind of have a gauge of what's happening with the kid. So, with the primary assessment, you form a general impression. Every call, you formalize a general impression. Rapidly identify the critical patient. Identify this critical patient, an essential component of pediatric assessment, and then make the following observations: mental status, interaction with the environment and others, and an emotional state. So right there is a good thing. So make your quick decision. You walk in, you got your general impression: sick, not sick, and that's kind of what you're going for. The second one, the third, then you go up there, and the second thing you're doing is any critical life threats that you see with your assessment. Oh man, there's difficulty breathing. They're really retracting. So stop. You're getting that kid on some oxygen with possibly a neb, and then essential component of pediatric assessment. So now you check the mental status. So now you're putting the baby on a rebreather, or it depends on the age of the kid, but you got a rebreather with a neb. Going at the same time. Now you're finishing up your assessment. How's the mental status? How's the kid doing with interactions and emotional state? So that's kind of general impression right there. And so you walk in, kid's sick, not sick, retract, so difficulty breathing, retracting, so you know what you got to do there. Then you go through how's the kid reacting to the environment, how's the kid responding to you, how's the kid's emotional state, panic, not panic, sick, not sick. So all that's done within 10 seconds when you walk in a room. So make the following observations. How's the kid responding to you? Tone and body position. When the kid cries, how's the tone? Is the kid tripoding? They can tripod. Um, Retractions, not retractions. Mucusy, not mucusy. Pupils reactive. All that stuff. Work of breathing, like I just said. Quality of speech. When they cry, is it crackly? Is it wheezy? Is it absent? Is it, and then are they cyanotic? Are they pink, warm, and dry? Are they diaphoretic? All that kind of stuff. So all that's part of the same thing. So you're forming your general impression. So the thing about this is you may be doing 2 or 3 slides of bullet points, but all of it's done in 10 seconds. So this slide here is done the same time as the first slide. When you walk in, this scenario starts. Boom, you're in the door and you're checking for all these things. So you walk in and you're looking at that baby and you're doing a head to toe quick rapid assessment with your eyeballs. How's the kid responding to the environment? How's the kid, what's your first primary impression of, is he sick, not sick? How's the airway? How's the skin color? And how's he reacting? AAO times 4, 3, 2, 1, where are they at? So all that's done right there. So, and then you go on to the head, you can read this out here. It kind of says, you're going through the head. Primary assessment is the same as a trauma patient, head to toe, but it's with your eyeballs before you get to the kid. How's the head size? How's the retractions? How's the skin color? All that. So, the primary assessment of the pediatric patient, so the mental status: alert, verbal, painful, gently tap unresponsive infant or child. So you're gonna have that. You walk in the room, kid's not responding. Tap them on the foot, tap them on the sternum. See what kind of response you get. Um, but you want to know, are they alert, verbal? How they, it's just a Glasgow. How do they respond? Walk in like, hey, even though the kid may not talk, maybe you know, the pediatric patient's not going to talk to you, but when you say, hello, I'm Scott with the Cheyenne County Ambulance, the kid's going to look at you. I mean, it's a kid. I mean, it's just, so do they respond to you? So are they alert? Do they respond to verbal? Do they respond to painful? So you got to determine that. Assessing airway, consider whether airway is open or endangered. Be careful not to hyperextend child's neck. Got to be careful, that neck's pretty fragile with a big head, little body, but at the same time, want that airway patent. So nothing new here than any other assessment. Um, but you want to know, when you're walking up to the patient or take care of the patient, check the mental status. Do they have flaring of the nostrils? Do they got pale or blue lips? Stridor or grunting? And again, that's that retraction work. Do they have stridor sounding? Are they gurgling? Are they retracting? Whatever. Are they? Is their breath rate proper? Is there retractions of muscles going on? Wheezing, working hard, decreased muscle tone, poor peripheral perfusion. So in the limbs, there's not good perfusion going on in the hands. Um, are their abdominal muscles working extra hard to breathe? Because remember, these are diaphragm breathers. So it starts with retraction, but then you're going to see that belly going up and down, up and down, up and down, up and down. We'll try to find a video to show you. But that's going to be important as well. All those are signs of distress. Assessing the breathing, chest expansion, work of breathing, sounds of breathing, breathing rate, and color of the skin. Nothing, and the cool thing I keep re-saying this to you because I want your mindset to be there is nothing that we're saying is new, right? We do this with all the patients. It just looks a little different in a pediatric because you're always going to do your primary assessment when you walk in a room. We've said that. But with a kid, it's just a little bit different things to look for, okay? So, and we'll talk about those differences in class. Primary assessment, pediatric, is still assessing circulation. Again, I've already said this. Are they pink, warm, and dry? Do they have a normal pulse rate? Check cap refill in infants and children 5 years or younger. So cap refill, 5 year. And then check for and control the blood loss. So nothing new there. I just was reading to see if there's anything big. But so it's going to be the same as an air call. You want to know all these things are. Do you want where's the skin color at? So that way, what are you trying to find? Are they perfusing? Normal pulse. Are they tachycardic? Are they bradycardic? Or are they normal? Because that would be signs of lack of perfusion or shock. Check capillary refills, and then check for control any bleeding. So that's a capillary refill on a young one. You do it at the hand, take your thumb off, and see how fast it takes to refill. Identify priority patients. So a patient who gives a poor general impression, is unresponsive or listless, does not recognize the parent or primary caregiver, and is not comforted when held by the parent, but becomes calm and quiet when set down. So those are signs of, man, we got to get moving. We got to take care of this kid. Because obviously, if the kid's unresponsive, duh. But then the fact that maybe the kid is not awake, alert, and oriented when he doesn't recognize the mom or the dad. And then the other thing you gotta look at is, why is he not being comforted by the mom or dad, but okay when they're put down? Why? So identifying priority patients. So one of the things you want to do is, if they have a compromised airway, okay, they're obstructed, is in respiratory arrest, or has inadequate breathing or respiratory distress. Because you got to remember, kid or not kid, kid or adult, don't matter. If they're in respiratory distress, you got to be ready because they're going to potentially go into arrest. So you have to take care. These are signs of, man, let's get going. Let's get ALS moving. Let's get, has a possibility of shock, and has uncontrolled bleeding or has experienced a significant blood loss before EMS arrival. So kid cuts himself, doesn't take that much blood volume, right, to lose in a pediatric. So you got to be ready for shock. So there you go. And the thing is, in that kind of ambulance, when you're in that situation, there's nothing like, I kid you not, there's nothing like having a child, a pediatric, in the back of an ambulance. It's not fun, but man, it's a very satisfying feeling when we do our job and we're able to help. But it's scary, but satisfying when you're able to help. So ask simple questions. Yes, no. Make sure you're not looking necessarily for open-ended questions with kids as much as you are with adults, but ask simple questions that cannot be answered with yes or no. So if you don't want to. What I mean by open-ended is you don't necessarily have to be pulling as much out of them as you do with adults, but you want to check their status. You want to know how they're responding. Perform a physical exam for a medical patient and rapid trauma assessment for a trauma patient. Explain all those steps. So medical, you sample OPQRST, you're going through the medical stuff. Explain to them what you're doing. I'm listening to your breath sounds. I'm checking your BP. We're going to check your blood sugar, all that stuff, right? But then the other side is you want a head to toe assessment of the trauma. It's all the same, but explain yourself. I'm going to feel your head, see if there's any um, bleeding. I'm going to check your face. I'm going to check, do your whole thing and record the vitals. Um, just like that. And I've had this before where a kid was very, very, very sick, and I had to check his blood sugar, and that kid hated me when I was done with that. Like he just looked at me like, "What did you just do?" But you got to do it. So do what you got to do. Start with toes, trunk, and work our way towards the head. So you can explain yourself. I'm at your feet. Just check in. I'm at your, protect child's modesty. You don't have to be weird. You don't, be respectful because nobody likes to go in an ambulance. It's not like what we want to do every day as a patient. So, but you got to make it also try to make it a good experience for them to know you took care of them because I always look at it this way as a kid, you're kind of painting a picture of their view of EMS for the rest of their lives in some ways. So make it a good experience, be respectful, and explain why each piece of clothing must be removed. Okay? If it's a trauma patient, hey, I got to take your shirt off, make sure you don't have any bruising, you don't have any, we just got to see, we'll put a blanket over you. Hey, we got to check your hips and, explain all those things to them. And if you're going to do that, it's best to have a family member around if you can, but no big deal. Head, do not apply pressure to the fontanus. So if you have a trauma patient, be careful with that fontanus. Meningitis and head trauma can cause bulging of the fontanel. So meningitis is not a good thing to see. I've never seen it, but I've had friends who've had it, and it's going to expand that fontanelle versus dehydration, which is going to have it a little bit indented. Collisions can often produce head injuries. Kind of funny how that says that. Collisions can often produce head injuries. In case you didn't know that by now in chapter 33. Nose and ears. Look for blood and clear fluid coming out from the nose. So look at what kind of stuff's coming out of the nose and ears. Again, clear fluid is not good. Suspect skull fractures if either is present. So really, if you got clear fluid, definitely probably a head trauma. Absolutely. I mean, clear fluid is either spinal or brain fluid. So you want to be looking for those things and know what you're dealing with. The mucus or clot obstruction will make it hard for children to breathe because it doesn't take much again to pack that airway shut. So suctioning and all that kind of stuff will help. You can deliver oxygen to an infant using a blow-by, which is basically just what he's doing with the tubing there. Instead of putting it on the on the nasal cannula or whatever, just have it blowing into their nostrils. Because obviously they're not going to keep things in their nose or anything like that anyway. So blow-by is perfect. Non-rebreather, just sit on the pillow next to them and let it blow in their face. Vulnerable to spinal cord injuries. Children have proportionately larger and heavier heads, and muscles and bone structures are less developed. So maybe sore, stiff, or swollen. So do your physical exam just like you would anybody else. Keep the airway open. Put some blanket and pillows under the shoulders to help them. And then if no suspicious or spinal injury, place that towel. So like I said, so that will help. As you saw the picture earlier where he's obstructed because of his head so big, put shoulders, it leads it back and straightens out that airway. Excuse me. Chest, be alert for wheezes. Check for symmetry. Equal and reactive on both sides, right? So check for bruising and check for paradoxal motion and retraction. So, look, do your whole assessment over the chest. You look for the same stuff. Flail chest, unequal chest rise, paradoxal motion, bruising, all that. And then with the abdomen, um, sorry, yeah. So then with the abdomen, note the if it's rigid, do the four quadrants. Check for tender areas, distension, abdominal injury may impede movement of the diaphragm. That's what's different with a pediatric versus adult. It takes a lot of fluid buildup inside the abdomen to push against your diaphragm and impede that movement. Not with kids that have a smaller body, right? So it doesn't take as much to shut that or push against that diaphragm. Pelvis, check stability, pelvic girdle, do the same thing. Cap refill, distal pulse, motor sensory, same thing. Reassess mental status, maintain open airway, monitor breathing, and reassess the pulse. Okay, so you're going to do your first primary assessment head to toe, same as you would do anything else, so just know that everything's smaller. So if you notice through our assessments, you're doing the same thing as you would with an adult or a larger person, but there's small details that are different in it. One, it doesn't take as much fluid in the abdomen, so note the rigidity and watch that diaphragm movement. Second thing is the airway is obstructed just by laying in supine, so you put a pillow under them, right? So all that those are just small little differences, but other than that, you do your primary assessment, take care of life threats, and then you do your secondary assessment and monitor skin color, temperature, and moisture. Reassess vital signs every 5 to 15 minutes, depending on the stable, not stable, and ensure all appropriate care and treatment are being given. Um, Maintain an open airway. So align an open airway. Use head tilt chin lift if no trauma. Remember, it's only if there's no trauma. Use jaw thrust with spinal mobilization, so just like you would anybody else. And then suction and check blockage of airway by tongue. And there you go. Everything's smaller, so you just got to do everything smaller. And we have all the stuff you need for a pediatric, but that's an OPA. That keep the airway open because that tongue is larger than adult, so you put that OPA in, keep the airway patent. An NPA, same thing. Put it in the nose. If there's no facial trauma, put an NPA in. Have them ready. So when you clear an airway obstruction, like we said, we don't necessarily do a finger thrust. So place patient in position of comfort, offer high flow oxygen, transport complete obstruction, perform airway clearance techniques. And so with that said, there's the back thrust. Remember your CPR chapter, back thrust, CPR, just 2 fingers. So just go back to make sure for test purposes, you just reassess your CPR techniques. But if it's severe, position of comfort and all that don't matter. Actually, don't matter because you're not going to get it in there. So get the obstruction out of the way through your back thrust and chest thrust. So back in chest, back in chest. So when you're providing supplemental oxygen and you're ventilating, high concentration oxygen should be administered to children in respiratory distress. So just like an adult, high concentration oxygen. When someone's in respiratory distress, obviously you want to help by giving them high flow O2. Those with inadequate respirations are in possible shock. So there's no difference, as I keep saying, and the reason I keep saying it is I want you guys to process the fact that there's not much difference in how we treat a pediatric versus adult. It's just a matter of using equipment that is set for the smaller mechanics of pediatrics. So you give them high flow oxygen, and if they're in adequate respirations, they're possibly in shock. So then you got to think about how you're going to ventilate that. So young children are often afraid of an oxygen mask, so it's uncomfortable. So you can do it a number of different ways. One of the ways they've listed here, which I've never done, is push oxygen tubing through a paper cup and blow it directly at them. But the one thing you got to look at is blow by oxygen is okay, with pediatrics. A lot of times, if you have a neonate or a young child, 1 to 3 or whatever, blow by is okay. Non-rebreather mask is preferable, but again, they're not all going to like that. So again, non-rebreather is preferred. So when you go on from there, some guidelines is avoid breathing too hard through the pocket face mask if you're going to use that to help ventilate for them. or using excessive bag pressure and volume. One of the things that we're starting to carry in Cheyenne County hospitals working on getting it to us is PEEP valves. We'll teach on that a little bit more when we teach on BVMs, but it was in your airway chapter, so you can kind of set the PEEP to pressure. Because the main thing is the mechanics are smaller, smaller trachea, smaller airway, smaller lungs. Very easy to puncture a lung from too much pressure. Use properly sized face masks to ensure a good seal mask. One of the things that they really are pushing us to get away from nowadays, which is not my favorite thing. I mean, I don't really agree with them. Is the C when you're holding the BVM, the C grip, where you just basically use your hand in the shape of a C and hold it. They're now saying it's got to be two-man job, two hands holding the mask down to seal it. But you know, out here you might be by yourself, so do what you can, but make sure to have the properly sized face mask to ensure a good mask seal to make sure no air is escaping that seal. Um, Guidelines is flow restricted. Oxygen powered ventilation devices are contradicted for infants and children. So basically, we don't use that in any way for our. I don't believe in our BLS stuff. So, but it is not a good thing. When you ventilate, it is ventilation is not successful in raising the patient's chest. Perform procedures for clearing an obstructed airway. So basically, same thing as in CPR class and everything else. If you don't have good, anytime you do airway, just anytime, whether you're gonna eye gel them, intubate them, king tube, BVM mask, anything. When you're breathing for them, you look for good chest rise, and then also use your stethoscope and listen for breath sounds to make sure there's um, a good positioning and everything's working. I've seen doctors even mess this up, and I've seen where they didn't have a good seal, but they didn't do look for chest rise, and the person didn't make it, and probably wouldn't have made it anyway. But the chances are, potential is, when we do these things, we want to know we did everything possible. So just like anything else, if you're breathing for them, make sure you're getting good breath. Look to the chest for rise and listen for breath sounds, and look at the belly. If you're getting when you tube, sometimes you can get air into the belly and not the proper spot, and you got to redo it. So just check those things. Um, that's a blow-by method right there. So just a little tube blowing the air into the nostrils. So that's a totally great thing to do for a child. Um, and there's the mask, correct placement. So you can kind of see you put. I mean, obviously the triangle is triangle, so the tip goes up the nose, and you know how to put a mask on. But we just always want to make sure we have PEDs available for us, PED mask, and then providing so ventilation with a pocket mask. Those are great things to have. When you all pass, we'll hopefully get some jump bags made for you, and all of you should have those, especially if you live in Wild Horse or Arapahoe area, um, away from an ambulance. Be good to have. So caring for shock, and I do apologize. I have kids running around today. I'm teaching from home, so if you hear kids, you hear kids. If you hear me yelling at them, just ignore. But caring for shock, common causes of shock in infants and children. So some signs are diarrhea, vomiting, infection, trauma, um, blood loss, allergic reaction, poisoning, cardiac events. Things that we don't think about is when it's flu season or stomach bug season, everybody's vomiting and sick. I've transported many patients, especially last year. I was really busy during January, February time. Um, when you're vomiting, and you're not getting fluids in, what happens? You don't perfuse. You go into shock. You're not getting good. Your fluid is not getting that fluid replacement. You go into shock. So we don't always think about just simple sickness that can cause shock. We look at trauma and blood loss and allergic reactions. But we got to remember during those times, if you're going to run on a geriatric patient and a pediatric patient, and they've been vomiting, chances are they can go into shock. So we got to look for it and then treat for it. So you can look at some things in this picture in your book to show different signs and symptoms of shock in pediatric patients. They're going to be rapid, so they're going to be rapid respiratory rate. They can have a weak pulse, but a rapid weak pulse. Um, Apathy or lack of vitality. They look kind of just lethargic. They're not responding to you. Their mental status is altered. Pale and clammy skin. Um, One thing to look at with kids that's kind of cool is do look for those absence of tears. If they're crying, but you don't see tears. There's not fluid. There's not fluid. There's shock. Fall in blood pressure, which is so a lot of these are the same as you would see an adult, but it's an infant, so you want to look for those things, and you're not always going to see the in your face signs like you do with an adult. So look for that apathy look. Look for that lack of vitality. Um, because that lack of vitality can also show an altered mental status because you're not always going to tell a mental status on an infant. So just some things to look at. So caring for shock is ensure that airway stays open, open it and stay open. Manage severe external hemorrhage. Again, take care of stop the bleed. Provide high concentration oxygen. Lay patient flat. Keep patient warm and transport immediately. So um, protecting against hypothermia is you want to make sure that head is covered. That's where most of the heat's going to leave in an infant is through the head. And then the torso. Keep the compartment warm. Avoid rough handling. Be gentle. Consult medical control about active rewarming of patients. So if they're already cold and they're already in hypothermic, again, we don't rapidly warm them up. So seek medical control just to cover yourself on how you want to warm that patient up. So in pediatric medical emergencies, if they're in respiratory disorders, likeliest cause is the cardiac arrest in a child or rather than trauma. So I have seen kids, and you've heard them too. They go to bed and they don't wake up. It's just a freak thing that can happen with infants and children. You just don't always expect it, but like I said, kids crash and they crash fast. So likeliest, the biggest thing that you're going to run on is either a trauma or a cardiac arrest. Distinguish whether probable cause is upper or lower airway problems. Find out where the airway issue is. Care for upper airway obstruction, not indicated for lower airway disorders. So, care for the upper airway. So if you can see things, just take care of that upper, but lower is just like anything else, you can't. So critical to be alert for early signs of respiratory failure. So if they're in respiratory distress, they're going to go into respiratory arrest eventually. So you got to find out what's the cause, what's the problem. Is it a sickness? Is it a RSV? Is it any of those things? And then what you got to do from there is just make sure to treat properly and be ready for respiratory failure. Numbness of diseases or number of diseases or disorders ranging from less serious to serious. So I have ran on epiglottis. It can be pretty darn scary. A cold is a cold. You're going to see it. Now you're going to see a lot of RSV, a lot of croup. Because one thing is croup and these little viruses that do nothing to us as adults are pretty traumatic on a kid. So you're going to run on a lot of those probably even this year. You guys pass January, you start running February or whatever we do. You probably have a good chance you're going to run on some of these with your ride-alongs. So anyway, you just got to look at what it is. Minor, not minor. Serious, not serious. Our job is to recognize signs of early respiratory distress and treat it before it advances to life-threatening stage. So differentiating upper airway problems from lower. Upper airway disorders affects mouth, throat, larynx. It could be an obstruction, it could be a trauma, it could be swelling from burns, an infection, commonly identified by difficulty breathing, stridor, or difficulty speaking. So that's one way you can tell when it's an upper airway, just like anybody else, is the stridor and the breathing. You gotta think about what does it sound like, and like we said, go to YouTube, go to some of these other links that we've sent out to you guys, listen to the breath sounds. Difficulty speaking. So one thing with adult, when we're in respiratory failure, we're trying to talk, we're using every other word. It's just really hard. Same with kids, but they may not be chatting, but crying is difficult, screaming is difficult. Just look at those issues. So when you're kind of trying to find the difference between upper and airway and lower airway affects large and small bronchial tubes and the alveoli. So again, there's not going to be that gas exchange. So asthma, pneumonia, other respiratory infections, commonly identified by difficulty breathing, wheezing, lung sounds. So remember, stridor's high, wheezing's low, and when it affects the bronchial tubes and the alveoli, it's really those are the diseases. That's the asthma, COPD, um, emphysema, and then when you're sick, pneumonia. And pneumonia can actually lead to those other diseases I just talked about. My dad died of COPD, but he had pneumonia 3 years in a row as a kid, which affected that alveoli, and it just was a lifelong chronic situation after that. So just remember, though, what the alveoli does, what the bronchial tubes do. So when you do run on these people, you know the anatomy, so you can also look for what you know, find what you're looking for. No, are you going to treat for asthma? Are you going to treat for pneumonia? Um, and then identify wheezing versus stridor. Nasal flaring is big in kids. Remember, there's those retractions at the clavicles. So when you see those kids with the nasal flarings going on and they're retracting the clavicles, that is a sign of respiratory distress or failure. I mean, they're not in failure yet; they're in distress. Use of abdominal muscles. Their bellies are breathing hard because remember that their body is smaller, so it doesn't take much to push against that diaphragm. Stridor, which is that high pitched, harsh sound, which we said, so we know it's high, and then audible wheeze and grunting. So my daughter had RSV like 3 years in a row, and it was every year it was really bad. Nasal flaring, the retractions, the high wheezing. Um, it took some breathing treatments to help calm that down. So watch for those things, and then you can make your judgment call on how you're going to treat. Breathing rate greater than 60 breaths is fast. Altered mental status, um, slowing or an irregular respiratory rate. So it's slowing and it's not regular. So breathe in, breathe out, breathe in, breathe out, right? This is more breathe in, breathe out, wait a while, breathe in again. So it's not consistent. They're cyanotic and their muscle tone is decreased. They're not as strong. They're weak, poor peripheral perfusion, and decreased heart rate. So they're going bradycardic. So you got to look at their breath rates are going up, but their heart rates are going down. So they're not a good sign there because that means they're not perfusing, and then it's downward spiral from there. Um, croup, which is a mild fever and some hoarseness. If you're a parent, you've seen croup. I'm pretty sure. That's when you put your kid in a shower, steam the bathroom up, take them outside in the cold weather, open up that airway. They have a loud, sealed bark. It's pretty scary when you don't know any better. Difficulty breathing, the signs of respiratory breathing, and restlessness, paleness with cyanosis. So the thing is with croup, if you're a parent, like I said, you've seen this, and it's a scary sound. When you don't know necessarily the training that goes along with it, and it sounds pretty crazy, but you steam up that bathroom and put them in there, right? It opens up that airway. Same if going outside in the winter, that breathing that cold air. It sounds crazy, but I have asthma apparently. Never been diagnosed, but I mean, I guess I have been diagnosed, but not just a doctor saying, "Well, it sounds like asthma. Let's try this." Um, but my whole life, there's times where I get to a point where, for no reason at all, lose my breath. I can't catch my breath. My alveoli is not working, so I can tell I'm not getting gas change. I'm getting lightheaded. But what's interesting is my body just takes care of itself. When I was a kid, even I just stick my head in a freezer, and that cold air would open up my airway to help me breathe. It's just crazy how your body works because I didn't know how to do that. Just kind of like, man, I need, just like I need cold. My brain's just like put your head in a freezer. I mean, it doesn't make sense, but your body does take care of itself, and I just don't think we always listen to it. And the same thing with croup. If we stay calm and we just avoid all the distracting factors that go along with it, you can open up that airway pretty easily. And like I said, as a parent, we've done that. So just remember when you go on a call and the parent's scared, comfort them, comfort the patient, but look at the fact that mild fever and some hoarseness. Look at do they have a seal-like bark? Are they struggling to breathe? Are they restless and pale? And then also cyanotic with it. If that's the case, it's probably croup, and some breathing treatment will do just fine to help that. Respiratory disease. So when you got epiglottitis, sudden onset of a high fever quickly, painful swallowing, or can't swallow, often drooling because they can't swallow, tripod position. and that's a when they're in a tripod position, they're in respiratory distress. Patient sits very still, appears more ill than with croup. Because with croup, they'll be somewhat normal, functioning normal. They'll still be playing. They'll be tired quicker and rest more. But with this, they're not moving. They're sick. All their attention is going to trying to breathe. Um, and so that's a more of a scary deal because they can't swallow. I had a patient one time that couldn't swallow anything. It was nonstop suctioning through the whole treatment just because they couldn't swallow nothing. Um, Other pediatric disorders, so patient care for a child with a fever, remove child's clothing, cover in a towel soaked in tepid water if local protocols permit. We've never really done that. I guess that's something we can discuss about our protocols here in Cheyenne County with that. Um, Never really done that. We just, but it's not a bad idea. Monitor for shivering. Um, then follow protocols for water or ice chips. So basically, if they're in a fever mode, you want to cool them down. Um, but I guess primarily if you're gonna, anyway, for testing purposes, man, soak that with tepid water is good. Monitor for that shivering, and then ice chips will help as well. Patient care for a child with a fever. So transported if patient suffered a seizure. I've had a few kids that just had a fever, had a seizure because of a fever. And really, some parents just don't know, and it's okay. I mean, it's a training thing. Um, they give Tylenol. I've really ran on kids that had a fever and they or had a seizure because of a fever, and nobody gave them Tylenol. So we gave them Tylenol, and it helped. But then you got to transport because it's the first seizure, and chances are they may never have a seizure again because it was a fever, but you still got to transport them anyway, and train the parent on Tylenol. You don't want to put them in cold water, and you don't want to use rubbing alcohol to cool a patient. I've never used rubbing alcohol anyway to cool a patient, but primarily it's just air. Take unzip their shirt, whatever you can do to get a little bit of cool air going on there. But chances are, if they had a seizure because of a fever, Tylenol is going to help, and just transport. Patient care for a child with meningitis is that's a scary disease. Check the ABCs, check the vital signs, get that baseline so you can follow trends. Um, High concentration oxygen by non-rebreather mask is absolutely necessary for meningitis, and ventilate or pocket mask if it's necessary. So basically, watch their vital signs, and if they are not breathing adequately, um, definitely breathe for them. Get that resistant or get that high flow oxygen going, but probably won't need a pocket mask, obviously, unless they go unconscious. Now, meningitis, it can happen. It can happen quick. Um, I'd say this is put them on high concentration oxygen pending the vital signs, and have a BVM mask ready for backup to that, and have a pocket mask backup to the BVM mask. Provide CPR obviously if it's necessary, and be alert for seizures. The meningitis can cause pretty high, pretty good chance of a seizure activity. So if you also run on someone that had a seizure because of a fever, you can't rule out meningitis. So that's where you kind of watch those vital signs to see, is this just a RSV fever or is this meningitis fever? Because then with meningitis, you got potentially more work coming ahead of you. And then transport immediately. Patient care for a child with diarrhea or vomiting is maintain that airway, provide oxygen, contact medical control if signs of shock are present, and again, because they're losing a lot of fluid and they're not replacing that fluid, shock is potentially there. If protocols allow, offer the child sips of clear liquid and chipped ice, and immediately transport. Our protocols, I don't care if you give them ice chips, and I don't care if you give them sips of water if they keep it down. Kind of strange that in this list here there's not an IV, because giving them IV fluids would be a great idea. Not fun to give an IV on to an infant or a pediatric, but if you have to, you have to. So I'd say call medical control on that. You're more than welcome to call medical control and ask the hospital, want me to get an IV started. Chances are they will, because mainly you got to look at the fact that whatever you don't do in the field, they're going to do at the hospital. Whatever they got to do at the hospital, it slows down even advanced treatment from there. So if you can get fluid going, do it and help the hospital out. Other pediatric disorders that you're going to see is patient care for a child experiencing a seizure. Maintain the airway. Do not put anything in the airway. Just make sure they're in a position where the airway is open. Position on the side if no spinal injury. So it depends what the seizure's from, right? If they fall and they're having a seizure because of trauma, you're not going to turn them on their side. You're going to spinal them and go from there. But um, be alert for vomiting and suctioning. Get the suction ready. Provide oxygen, transport, monitor for an adequate breathing. And altered mental status, I mean, it's going to be there. You're going to have an altered mental status. There's always the post-ictal phase after a seizure. It takes a while. But, you're going to run on seizures. I've had a lot of seizures. People have seizures. There's a lot of it in our area. Um, so the fact of the matter is you're going to see it. So put them on their side is a great thing as long as you know it's not trauma. Because if they're having a seizure, they're not going to swallow per se. So you're going to have some suctioning to do potentially and um, all that kind of stuff. So monitor them and then watch their altered mental status. So if they have a seizure, they're going to be postictal, but kind of note the times. Okay, so it was a 2 minute seizure and they've been postictal for 5 minutes because that helps the hospital know how long was the seizure, how many seizures. So kind of like this is sometimes you can have a patient that had one seizure, it was 2 minutes, postictal for 5 minutes, went back into a seizure for another 2 minutes. All that, note that all for the hospital's sake, so they know how to proceed as well. So just tell them, I got a 4-year-old pediatric patient, had a 2 minute seizure at home, witnessed by the mom, been postictal for about 5 minutes. The airway is patent. Um, and went back into a seizure while we were there for 1 minute. And now they're postictal and we're en route to you. They're on high flow oxygen. All that kind of stuff that you want to tell and monitor is a good thing. Um, Assessment of a child with an altered mental status. Be alert for mechanism of injury. Was this trauma? Be alert for signs of shock. Look for evidence of poisoning. Look around that house. Decon, chemicals, cleaning supplies. Attempt to get history of diabetes and seizure disorders. Um, because the thing is, so sometimes you're going to show up, you don't know if there's a seizure. Nobody witnessed a seizure, but the kid's got an altered mental status. So you look around it, did they fall? Is there any signs of a fall? Are they in shock? Where's their heart rate? Where's their blood pressure? Um, and then always keep your eyes open for that poisoning that could have caused that altered mental status. Did they get into dad's whiskey? Did they get into some cleaning supplies? But then, ask the family. Is diabetes in your family? Because this could be the first diabetic event for this pediatric. And so check the blood sugar as well and rule that out immediately. Anytime there's an altered mental status with a pediatric or an adult, one of the first things you do is a blood sugar. And then, is there a history of epilepsy in the family? Because this could be the start of that for that poor kid. So all those things are going to be important, but key to altered mental status is always blood sugar needs to be ruled out immediately. Patient care for a poisoning, contact medical control or direction, or poison control. So when you guys pass, we're going to make sure you have all this stuff's in the ambulance, but I want you guys to have poison control in your phones. Because if you run on something you don't know what to do, get on poison control. They're going to help you out immediately, and it's awesome. Consider activated charcoal if protocol allows, which we do, as long as whatever they ingested. Again, it depends what they're poisoned with. If they are going to vomit and whatever they're poisoned with is going to tear up that airway on the way out, not good. We don't do that. But if they took a bunch of oxycodone they found in the bathroom, uh, and it's within an hour and a half window, throw some charcoal in there, absolutely. Provide oxygen, transport, and then keep watching their responsiveness and reevaluate vital signs every 5 minutes. Um, Care for unresponsive patient is ensure that airway stays open, provide oxygen, and be ready to ventilate. And anytime you put someone that's unconscious on oxygen, have that BVM mask ready to go as a backup. Transport, contact medical direction, and poison control. And then obviously rule out trauma as well, just in case you don't know what the cause is for the unresponsiveness. If it wasn't witnessed, you can't rule out that trauma. So And with that said, again, if you can't rule out trauma, so they're unconscious, nobody knows why, you don't see signs of poisoning, but you're not sure because nobody witnessed anything. Um, Rule of thumb, you can't rule out trauma, so spinal them. So ensure the airway's open, spinal them, provide oxygen, have be ready to ventilate for them if you need to, transport, and get a hold of medical control. Patient care for a drowning patient is, definitely artificial ventilations or CPR. So, depending on where they're at, right? If they got a pulse and they're breathing, provide them on oxygen. If they are unconscious, start CPR. I mean, if they're pulseless, start CPR. Protect the airway. Consider spinal mobilization. Um, that really is going to matter pending why they drown. Did they dive off the board and hit the bottom? As long as if you don't know, spinal them. If you do know that they just lost their, just drowned because they had trouble swimming, you don't need to spinal them except for the scoop stretcher is going to help you carry them around. But protect the airway, consider spinal mobilization, protect from hypothermia, dry them off, and treat any trauma and transport. So, kind of a weird way they listed this stuff. I don't like the way they listed it. So, if if they're unconscious and pulseless, you're doing CPR. If you're doing CPR, you're going to board them. If you're going to board them, you're going to carry them because we don't let anybody die with us. We get them to the hospital. So provide the artificial ventilation while you're doing CPR. Open up that airway. Consider spinal mobilization. Keep them warm. You're going to dry them off because you're going to put an AED on. Treat any trauma that you might see, and then transport. So, um, sudden infant death syndrome. This is what I was talking about earlier. SIDS. It's just a random event of cardiac arrest. No accepted reason exists for why these babies die. Everybody's got their theory. I've heard suffocations. I've heard vaccinations. Um, it's hard to say what the cause is. Nobody knows. But treat as any patient in cardiac arrest or respiratory arrest. Resuscitate unless there is rigor mortis. So, um, rule of thumb with EMS, with EMTs, we cannot call death unless it's an obvious sign of death. So, if we go up to that patient and they've already got rigor, they're bloody, you can tell the blood's pooling, we can call that. We don't got to resuscitate and then help the parents out with that. However, if there is no obvious signs of death, we treat it like any other cardiac arrest. So we're doing CPR, we're doing compressions all the way to the hospital. So I apologize. This is a long chapter, guys. During a motor vehicle collision, unrestrained head and neck. So I don't know. Out here it's different. I know. I have an issue, and I think parents are too relaxed sometimes on how we transport kids in the car. I've seen kids run around the back seat, and I understand it's small town, slow, whatever. But sometimes these kids are unrestrained, and I have ran on calls where parents were in an accident, kid was not restrained, and all the damage could have been prevented. So you got to look at the head and neck, obviously. So during a motor vehicle collision, you got to watch that head and neck, and if they are restrained, look at the abdominal and lower spinal because if you look at a car seat, just the trauma is going to be where that seat belt is. Um, so if they're unrestrained, we take care of the head and neck as primary. If they're restrained, it's abdominal and lower spinal. Um, when struck by a vehicle, the head injury, abdominal injury, possible internal bleeding, lower extremity injury, possible fractured femur. So kind of repetitive from the trauma chapters we just went through. Um, so basically, anytime you run on a call like this, kid and not kid, look at the mechanism of injury. That's really what they're going through in the slide. It's probably in your book. When struck by a vehicle, watch the mechanism of injury, watch the impact, and that could have took place, and you treat accordingly. You do a head-to-toe assessment, take care of life threats, finish your primary assessment, and then make your treatment decisions based on your primary assessment, and then begin transport while working that system. So obviously the head's going to be a big thing. Abdominal injuries, possible internal bleeding if they got hit by a car, absolutely. We're going to treat for shock, check those vitals, get your baseline. Lower extremity injuries, possible fractured femur, absolutely. If they're on a bike and they get hit by a car, absolutely a possibility, right? So, but you're going to find that in your primary assessment. So in some ways, the book is kind of being repetitive here, but I understand, just do that head to toe, take care of those life threats, finish your head to toe, get those vital signs, and you know, treat according to your primary assessment and reassess and reassess. So that lady there got hit by a car. If she did, absolutely, she looks pretty darn good for being hit by a car. It's a good picture. But anyway, when you're on a bike, you gotta look at the impact, right? So the bumper is gonna hit your leg. They're gonna fly out of the car. They're gonna hit their head and potentially have some abdominal issues. Um, Larger, heavier head propelled forward. So sometimes with kids, with us, the part that's hard is sometimes just the whiplash can be damaging because their head is heavier than most of their body, so it's going to bounce, right? So respiratory arrest, common secondary effect of a head injury. Um, so a lot of times when they hit their head, they got some head damage. Respiratory arrest will usually follow that. When it's the chest, less developed respiratory muscles is going to lead into respiratory distress. More elastic ribs, more damage can be done with that, and deformity or injury to underlying structures. So, same thing as an adult, you go through your primary assessment, but keep in mind these kids are not developed to the point of an adult. So, everything is more connected in a sense of their heads are bigger, that can lead to respiratory distress, um, and then less developed respiratory muscles, so it's going to be more of a difficulty breathing. Less body mass, right? So it takes a lot less pressure to push against that diaphragm. So you do the same thing as you do with adult. Just keep in mind the mechanisms are different in the body. So head to toe, life threats, and I keep repeating that I know, but get that down. Head to toe, head to toe, head to toe. So when you get on a call, you're not trying to remember everything you read in the book. Muscle memory, primary assessment, treat those life threats, finish your primary assessment, get those vital signs, reassess, reassess, reassess while treating from your primary assessment. Um, Examine the head is the same thing. DCAP, BTLS. You're looking for any deformities and contusions and abrasions and all that stuff. Pupils are the equal and reactive. JVD, swollen neck veins, tenderness, crepitus. Remember, crepitus is when air gets into the muscle tissue. Um, Trauma can cause that. Disease can cause that. Um, so check for those things in there. You're going to examine that chest, right? Palpate the ribs, palpate the chest. Is it equal chest rise and fall? Is there any crepitus, signs of breathing difficulty, um, bruising, all that stuff you're going to look for. Um, and then right there, contents, same as an adult, everything behind the ribs, so it's good to have these so you can picture when you're palpating the chest and muscles and all that, what's behind there that you're trying to find. Listen for those breath sounds. Not enough EMTs listen to breath sounds, and make sure because there's four lobes of the lungs, right? So any lobe can collapse or all of them can collapse. So auscultate for breath sounds over all lung fields. Injury patterns, abdomen, watch for diaphragm and breathing. It can be a site of hidden injuries. So distension may interfere with artificial ventilations. Watch for vomiting. So if there's a internal bleed going on and there's distension, you see that distension, it can interfere with artificial ventilation depending on what's causing it, because it might stop airflow from getting in there. Be ready to suction. Be ready to turn over on their side. Manage the same as adults with the extremities. Um, Examine the abdomen, check for bruising, tenderness, guarding. Look for swelling that may indicate swallowed air. Um, because sometimes all that swelling is you push against it and it's just air pockets. Um, Abdominal quadrants, same, four quadrants. And so remember the anatomy and physiology of the body, and what organs are you concerned for when you're palpating. Divide the abdomen into the quadrants, examine each one while remembering which organ are located in each quadrant. And then examine that pelvis. This can be painful at times, but examine the pelvis for tenderness, swelling, bruising, or crepitus. If the patient complains of pain, injury, or other problems in the genitoury area, assess for bruising, swelling, or tenderness in that area. So, what I like to get my hands on that pelvis, and just push and squeeze. And if it hurts, you put a pelvic splint on. You know you got to take care of that. But also trauma naked. They're not doing it in the pictures, but if they have pain there, cut the clothes off. Is there bruising? Is there swelling? What do you see? Arms are the same way. Evaluate for pulse. Evaluate the pulses, sensations, and warmth. Look for unequal movement and strength. You know, just like feel down, palpate, 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 palpate. Squeeze my fingers, squeeze my fingers. Cap refill. You know, check for all those things. Legs, same thing. Palpate, 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 palpate. Push against my hand, lift against my hand. Right. Cap refills, pedal pulse. Check all those things. Going down the back and examine. They'll feel all the way down that spinal cord and tell. Do you see feel any deformities, any bruising, any crepitus? Um, and then keep in mind too, this can be done when you log roll them onto a backboard. Um, the KED, we don't ever use this anymore. It's amazing it's still in the training because nobody that I know of uses this anymore. But open the KED, place padding um, behind the patient, and you basically it's kind of a cool deal though. I like it. Head and body log roll the child onto the KED. The KED is great for children and for also extricating people out of the car. So I'm not sure why people don't use them anymore. I like them, and then wrap them up. They're packaged for delivery. Burns. Identify candidates for transportation to burn centers. Obviously, we're still going to KMH, but again, get ALS moving. Cover burn with non-adherent sterile dressing. Ensure open airway. Suction as needed. Immobilize spine. Transport immediately. So child abuse, I think this is towards the end. Types of child abuse often in combination. So psychological, emotional abuse. These are kids that like you said, watch how the parents they respond to parents and caregivers, um, and just everything about this is report, report, report. So you know what kind of situation you're putting these kids into or when they go home. Physical abuse and sexual abuse. Almost every imaginable kind of injury and maltreatment. Um, it's often called battered children, and a strange name, but you could tell by the social connection these kids lack of social connection, how they respond to you, how they respond to the parents. You can look around the house, you can look at them, and kind of see what's going on. But but anyway, so a lot of this is ranges. So adults exposing themselves to forcing sexual intercourse or torture on children. Um, very lot more common than you want to believe it, but it happens all the time. And no county and no area is immune to this. So um, cases in which abuse was only emotional or minor in nature are less reported, but it's still good to report on these things. Um, Signs of possible physical abuse is slap marks, bruises, abrasions, lacerations, incisions. Um, it's horrible, but I mean, you'll see bruises, you'll see hand marks, you'll see all those things. Broken bones, and there's ways of telling a broken bone from a trauma versus shady behavior. Head injuries, abdominal injuries, bite marks, burn marks. I've seen cigarette burns on kids, indications of shaking an infant, and that's horrible. That's horrible when you go on a call for shaking baby syndrome. I mean, because you got to imagine that nothing's developed yet, and the kid's being shook, and his head that is oversized is whiplashing back and forth, spinal injury, brain injury, horrible thing. Here's some bruises, child abuse injuries, bruised buttocks. Um, you can tell that that's not just a spanking. Okay, that's not just you're a naughty kid, you're getting a spanking. This is beyond that. That's just horrible. It just makes me mad. I'm just saying. But anyways, it's a whipcord, obviously of some kind. Signs of possible physical abuse, obvious signs of sexual assault. Um, you know, any unexplained genital injury, um, seminal fluid on body or clothes or other discharge associated with sexually transmitted diseases. If the child tells you he was sexually assaulted, I like that. So signs of possible physical abuse. If the child tells you he was. Um, anyway, Those are some signs that you got to look for when you're suspecting. Just keep your eyes open, be alert and vigilant for these things. Possible indications for an adult being an abuser, inappropriate concern about child, trouble controlling anger, seems to be on a brink of an emotional explosion, appears to be in deep depression, indications of alcohol or drug abuse, and suicidal thoughts. So, um, watch the watch the behavior of the parents in the room or the caregiver in the room. A lot of times they're going to be very concerned, primarily either how do you explain it, but either a kind of connection of concern that is inappropriate versus just a concerned parent, or you could tell they're concerned because they're worried about themselves. They're usually on the brink of an emotional explosion. You could tell they look like a time bomb ready to go off. We've all seen these kinds of people. Internal shaking. Um, you could just tell. It appears to be in deep depression, and alcohol abuse is around. You can see a lot of different things. Um, Dress and provide other appropriate care. So, excuse me. You want to excuse me. You want to preserve the evidence, so you don't want to wash everything away. You don't want to over take care of things. Discourage the child from going to the bathroom because you want the evidence to stay, DNA, all that good stuff. Give nothing to patient by mouth. Um, IVs only if you're going to do anything. No sublingual medicine. Do not have child wash or change clothes. Unfortunately, that's the first thing they're going to want to do, but you got to keep everything the way it is. Take care of your vital signs, take care of any life threats, do what you have to do, but try to maintain. Gather information from adult without expressing a disbelief or judgment. So you're working with the parents. You don't want them to know that you're there's a suspect in your mind, but you want to get proper information from them. And when you're alone with a child, do what you can do to talk to them. Plainly and clearly report to medical staff and findings. So when you drop off that kid, and I've done this, I've had this situation, horrible abuse situation. When you drop them off, go to the proper authorities so that kid doesn't go back home to that situation. And then report it in your report. And we'll go through some training on this and documentation because you can't over-report on this. You got to be clear as day of what you seen, saw, and heard, and all that good stuff. Um, Use terms suspected and possible even when talking to a partner, hospital staff, police, or superior. Um, you don't want to accuse falsely. So I suspect, and there's a possibility. Contact state child abuse reporting hotline. Here you'll get social services on the involved. So what should you do to be concerned if a patient, or I'm sorry, what should be your concern if a parent in a possible child abuse case reveals suicidal ideas? Um, think about how you're going to handle that if you have that situation. And again, read your book and read your chapter for test purposes. But my from dealing with this before, usually it's if an adult is involved and they're suicidal, they become some form of a patient, really. So law needs to get involved, social services needs to get involved. Infant and children with special challenges. Common challenges: premature infants with lung disease, infants and children with heart disease, infants and children with neurological disease, children with chronic disease or altered functions from birth. So um, these are challenges when you have a preemie, their lungs aren't developed, they're jaundice usually. Um, I've met kids with heart diseases right from birth. I knew a kid that went straight from birth to heart surgery, open chest surgery, and everything. Um, Seizures, epilepsy, neurological diseases, all that kind of stuff. Um, so, so when you do run on a kid, sometimes they already have a tracheostomy. Potential complications is that can get obstructed. They can bleed from it. Air leaks can happen. The seal breaks and they can leak air. A lot of infections can take place with this or a dislodged tube. Not only can infection take place with a tracheostomy tube, but also take place with a feeding tube. These kids get affected a lot. Bacteria gets in there. Not proper cleaning. That's a huge problem. Um, so you're going to have to help with those situations, and it's tough. Um, Home artificial ventilators, so maintain open airway, artificially ventilate with pocket mask or BVM met with oxygen, um, and then transport. Don't waste time. Take that kid to the hospital while you're breathing for them. Um, Now, this is where I was talking about with central intravenous lines. So they have a possible complications is again infection is top of the list on that. You're going to see a lot of infections with those. Like I said, not proper cleaning, bacteria gets in there, it gets infected, they bleed from it, clotting off the line, and crack lines. And it's hard when these things are their lifeline and then they're not working properly. Emergency care is we apply pressure if there's bleeding and we transport the patient. We're not paramedics yet, we're not nurses or doctors, so all we can really do is control the bleeding, take them to the proper facility to get taken care of. Um, then the GI tubes and all that. Um, Poor kids, you know. Be alert for altered mental status and ensure the airway stays open. Suction airway is needed. Provide oxygen if needed. Transport sitting or on right side with head elevated. Um, so basically, when you're transporting these patients, after you check their altered mental status, you ensure their airways going properly. You suction as you need if they're sick, and give them oxygen if needed. And again, not everybody gets oxygen, so it's pulse ox, check the respiratory rate, all that stuff. Transport sitting, you want them upright. And then the right side, again, it's recovery position, elevate the head. Because you don't want everything to move towards the airway, you want everything to flow with gravity. Maintain open airway, ventilate with pocket mask or BVM and high concentration oxygen. Transport the patient with shunts. Um, so, wrapping up here pretty soon, I think. Psychiatric effects on EMTs. So now we're talking about our care. Pediatric calls are among the most stressful. Again, people panic, and I'm not saying I'm immune to this. Don't get me wrong. I've seen some horrible stuff, and with kids, and it breaks my heart. They still bother me to this day at times, just special moments. Um, but we may identify a patient with own children, and that happens. If you got kids and you're taking care of a pediatric, you're gonna relate. It's just the way it is. Um, it may cause some anxiety, and then most serious stress is over a very sick, injured, or abused child or child who dies during or after emergency care. Um, these are going to be stressful times for us. We're going to see these things. We're not immune to them. And if you have kids, we're going to relate. It's just the way it is. I have been on car wrecks. I have been with sick kids. And absolutely, I go home and I hug my kids a little bit harder. And unfortunately, pediatrics are not immune to the fallen world we live in. There's sicknesses, there's horrible stuff that happens. Main thing is you don't, and I'm not, don't wall off and don't be cold about it, but get the job done to take care of the kid. Push those emotions aside for a moment. Take care of the kid with the most professionalism and care that you can give them, and then deal with that after. And my preference is as a team that we deal with it as a team. None of us are lone rangers. We don't need to keep quiet about things that bother us. These are great moments, and I recommend almost every time that we do a debrief and chat about those calls and detox our emotions with them. You bottle them, that causes problems with you later on in life. So dealing with stress is we need to communicate and treat. Communicating with and treating children can be learned. Care mostly consists of applying knowledge of adult patients and adjusting for children. And I've said that, right? So um, when you get on these calls, you tackle it and realize it's just like an adult, just smaller, right? So we know the steps, ABCs, head to toe, life threats, control bleeding. We know all those things. The problem is when we get with kids, we panic a little bit without meaning to. So stay calm and be consistent and give the same knowledge to the kid as you do with adults. And then talk with other EMTs. Talk to us as a team. Talk with your service counselor. We don't have a service counselor in Cheyenne County that I really can think of. We have pastors around that help out quite a bit, myself included. We have just the right protocols that we can follow to help. Main thing is I would like us to be a team that can communicate together, help us walk through this stuff together, because we're just going to see stuff the rest of the world doesn't see. And you know what? I mean, I appreciate you guys and your dedication and everything you're going to help do to help this county. So main thing is read this chapter, do the best you can, give it everything you got. Take care of these kids. Love on these kids with your care and your passion, and we'll always work together as a team. Cool. So chapter review is basically go through and any questions you have, you can text me, you can call me. We can take care of these things. But appreciate it. I'm trying to keep up with these guys. We're getting there, man. We're getting there. Chapter 33. We're almost there, guys. So keep on it. Appreciate it. Talk to you soon.